my thanks to the Aidite family. We have been cooperating with Aidite for a while now. We have documented cases with their material, and we are in a global educational level, very close partners. And we're having a very smooth cooperation with Aidite. The topic that I would like to share with you today. So, in the past, I had some lectures with Aidite on monolithic full contour zirconia, on implant-supported restorations, tooth-supported restorations. Today, I would like to share the topic of ceramic veneers, two-cut manufactured monolithic zirconia laminate veneers, and trends in the market. Basically, I would like to share some interesting cases that have been done in our location, in our clinic, and some extensive follow-up of up to 6, 8, 7 years. Let me start with skip this slide now. My focus, my point is to discuss a little about our patients and their dental experience. So we are very close connected with our patients, and dentistry in general is considered a difficult and painful practice. So focusing on our patients and what is their expectation and their experience, I think, is very crucial. So until recent years in dentistry, we were mostly relied upon for pain relief, okay? Or the restoration of extensively decayed teeth. Most people had fear of course, going to the dentist. And dental visits were usually out of necessity or usually associated with pain. Okay, so until recently, dentistry was very much connected with emergency, with fear, and with pain. Our patients frequently left our office with missing teeth extractions or dentures. So this was pretty much the face of dentistry over the last many years. Excuse me. Aesthetics, which is an integral part of our lives today, was barely at the periphery of dental concerns. Okay, so dentistry had a totally different focus than is having today. Now, times change, thanks God, and so our patients today are exposed to media, which is greatly influencing their aesthetic perception. Okay, so media is an integral part of our societies, of our communities today. Awakened to beauty by the media, the public, our patients, became aware of the beauty of a smile, okay, and the attraction a beautiful smile creates. So accordingly, the dental profession began searching for cosmetic restorations. There is a substantial need for aesthetic dentistry today. Aesthetic dentistry is a big part of our services today. In the 70s, the adhesive bonding was born. We were not aware of the possibility of adhesive dentistry before the 70s. Adhesive dentistry is a major catalyst to the revolution dentistry would change forever. So today we are maybe almost only doing etching and bonding, okay? So the entire concept of dentistry has changed dramatically over the last 40 years. It changed totally, changed completely. Bonded bridges, laminates, and all ceramic crowns are made now possible. We can deliver this treatment to our patients. In that extent, conservative tooth preparation is nowadays possible. So we reduce the amount of tooth structure that has to be removed. Essentially, the presence and future of dentistry is bonding and luting. And this is also valid for zirconia and for all ceramic restorations accordingly. Today, we are going to deal with less aggressive tooth preparation procedures, which result to reduced tooth trauma, so less tooth trauma, less postoperative discomfort for our patients, and a high level of patient satisfaction. So today, we are able to be less aggressive, more conservative, and provide a higher level of patient satisfaction. So in the past, we had the must-based dental visits, and nowadays our dental visits have swifted to want-based dental appointments. Now, the aesthetic dentist is also a designer. So we are doctors, we are engineers, and we are artists. This is a conceptual part of aesthetic dentistry that we need to clearly understand. So the final result, the final outcome must be absolutely clear to the clinician before starting a case. The aesthetic dentist must be aware of the limitations of each technique that is going to be applied, okay? Plus the expected clinical performance of the materials that we involve. So we need to educate ourselves on the materials that we're going to utilize. We need to be also material specialists. And for this reason, dental technicians and dentists have to understand and to educate themselves in material science. Superior knowledge of tooth preparation is mandatory, plus the abilities to execute finishing touches for optimal results. Okay, this is pictures of a case that we will follow later on. In striving for perfection, we should strive for perfection, and the aesthetic dentist should be willing to expect excellence as a final result. So we need to focus on achieving the best possible outcome. The fine details will produce a superb clinical result, whereas if we use same technique but with less attention to detail or without attention to detail, we might end up having average results. Okay, so it's a matter of our own perception of our own team as dentists and dental technicians, material science, attention to detail in order to provide quality outcomes. Last chapter is about patient communication. In this introduction, you know this, I've been practicing aesthetic dentistry for almost 30 years now, and I would like to navigate you through some aspects that, from my understanding over this clinical experience, are crucial. Patient communication is extremely crucial. Now, the needs and motives in aesthetic dentistry differ from the previously mentioned conventional dentistry needs and motives. This is a different part of dentistry. Aesthetic dentistry is another chapter in dentistry. Need dentistry is dentistry. We decide about the results. Patients who are suffering, having pain and discomfort, need to be relieved. Okay, so this is a pain-driven dentistry, whereas aesthetic dentistry is want dentistry. So patients' expectations are usually, occasionally, very, very high. So when patients arrive for an aesthetic dental treatment, they are usually motivated and enthusiastic about beginning the case. It's the improvement in their aesthetics that they they desire. We need to understand their needs and personality in order to propose an appropriate treatment plan. Patients' satisfaction is of vital importance. Okay, it's extremely important that our patients. You need to mute, please. Dissatisfaction will not only be harmful to the patient's ego, but also to the dentist's professional reputation. So focus on the final patient satisfaction is extremely crucial. In that sense, our team needs to integrate patients as responsive members. So there is a lot of reference on this topic, many wonderful books, many wonderful clinicians, and anyone who is interested into aesthetic dentistry, either dentist or a dental technician, I would recommend, and I think it's very valuable, that they go and sorry, and search this literature. Let's have a look at some cases. So let's go to the clinical cases that I have collected for you, and let's start with this case. Young patient, fractured central incisor out of basketball, very tall player. I was called to help him as an emergency at a Sunday afternoon during a football match, basketball match. He fractured his central incisor. Now, when we see a clinical case like this, many times we think about composite buildup or a veneer, which is not necessarily always the best way. We can be even more conservative on some instances, okay? So here, the tooth that we need to deal is central incisor that is presenting a horizontal fracture without pulpal involvement. The tooth had been fractured in the past and was bonded 3 years ago. This is why on the left side you see some pulp capping material, this white spot that was used in the past. So we had a fracture at the same interface that we had previously. Now, abrasion for a dental and then for a cleaning dent and conditioning dentin and enamel is extremely important in order to provide luting surfaces that are clean. So sandblasting or polishing is a major tool in our office, so we use it regularly. Okay, now on the right side you will see the clean fragment that can be adhesively luted with rubber dam occasionally or without. It depends on the clinician's expertise. Or can use mini dam, which is a short rubber dam that allows for an isolation of 2 or 3 teeth in a specific area. And then conditioning, which is again using the sandblaster to clean the tooth surface in order to proceed with cementation. So adhesive luting of this component, and then the clinical outcome. You see, I'm not a tall guy, but well, he is really tall. Clinical outcome. In that sense, we occasionally can produce minimal invasive predictable treatments by luting the fragment back into place, which usually provides beautiful outcomes. So we didn't have any problem with this 6-7 year follow-up case. Okay. Now let's move to the second case that I would like to share with you today, and it deals with ceramic veneers involving the 2 central incisors. Young patient, just graduated from the dental school in Thessaloniki, so she's a certified dentist, and she would consider treating her 2 central incisors. So her chief complaint, which is a very important word to ask. We need to ask our patients, what is your chief complaint? Is this aesthetics? Is it pain? Is it function? Is it speech? They need to articulate properly what is their major complaint. She wishes her 2 central incisors to look better. So there is an aesthetic handicap for 11 and 21. She used to have she had a bicycle accident many years ago, and both teeth were treated with composite, which initially was fine, but over a year you see the surface texture, and you see the missing glaze, and you see the color that composite extensive restoration in these 2 central incisors should be replaced by another material which is long lasting. So our aesthetic analysis is usually focusing very much on tooth form, color, and surface texture. These 3 very important criteria we need to figure out, because from time to time we need to change tooth form, but not the tooth color, like in this case, and the surface texture is not appropriate. So, you know, actually, basically, in this case, surface texture is what bothers me the most. Again, excuse me, I will go back in this area, the lateral incisor. There is also a part missing. So we discussed about this with our patient. As she said, it's not crucial for her at the moment. She just would like to have the central incisors treated. We will do a radiograph to check whether we need to do some endodontic treatment. These cases are clear of endodontic treatment, and we can proceed with a diagnostic mock-up plus shade matching, of course, because it's important to discuss with our patients the option of bleaching, whether they would like to start with bleaching or whether bleaching would be necessary. In her case, we are at A1, so bleaching in this case is not required. Then we will go to a diagnostic mock-up, which is, we use hard composites like Luxatem usually, and a transparent silicone key in order to have an aesthetic baseline discussion with our patients, actually. So aesthetic approaches are usually a triangle involving the dentist, patient, the dental technician, and the mock-up is the area where we overlap our aesthetic approaches and efforts. So routinely, we go through a diagnostic mock-up, and if you want to take to have a take-home message, please always use the diagnostic mock-up and never proceed with treatment without analyzing with your patient the expected clinical outcome. For example, in this case, we deliberately gave an additional length to her central incisors because I think the dominance of the central incisors is quite important. But you know, after surface conditioning and glazing and polishing and so on, we can go back and discuss with our patient about the clinical proportions and if she's happy with additional length, because she needs to feel comfortable about her prospective smile. So using periodontal probe, we go into details and we discuss about the proposed length. And she feels that the teeth are a bit too long. So in this case, we use a marking pen, you know, a black marking pen, and we just figure out what length would be ideal for her. And we continue with tooth preparation. Now, our preps are finalized and our impression is taken, and 2 veneers out of Emax are made in the dental lab. We use lithium disilicate routinely in our dental office, and we don't do actually CAD/CAM restorations in our office in the anterior area. So usually we outsource this to the dental laboratory. But of course, many colleagues are experts also in chairside fabrication of veneers made out of feldspathic materials or Emax. These are the 2 veneers finalized by the dental lab, and we can occasionally, if it's necessary, we can check for the appropriate shade, because many companies are providing trying pastes, and we know from the literature that we can gain some difference in color by using different shades. So in this, because in this case we have, of course, very, very white teeth, for documentation purposes, I have included 2 pictures. One is with white trying paste and the other is with bleach trying paste. Now, adhesive luting is done under the prerequisite that the area, the tooth area, dentin and enamel that has to be used for adhesive luting is totally clear, and biofilm and any type of provisional composites are perfectly removed. So have a look at the surface of the area to be bonded before and after sandblasting, and I have used some close-up views because I would like to highlight how crucial and important it is to cement on perfectly clean and conditioned to the surface, sorry. This is the final aesthetic outcome with Angelica. And actually, I would say that it's a very successful outcome. We are very happy and very pleased with the result. I would like to have her centrals a little bit longer, but basically she's happy and they are, long enough. So form, color, and surface texture, our dental technician, our skilled dental technician managed to perform in a very beautiful way. And, 2 central incisors. So any case that is not involving laterals and canines is quite challenging. Okay, so we have a very nice outcome, and our dentofacial harmony is reestablished properly in this case. Now, 6 months post-SEM, the patient is rescheduled again in order to check occlusion and in order to check carefully for potential remnants of the luting cement, because from time to time, we need to go back around the gingiva in various areas and remove some little fragments of the luting cement. In this case, it was not the case. We have an optimal aesthetic outcome in Angelica in this specific case. And this close-up views will reveal the soft tissue integration that we can achieve with lithium disilicate. It's a very tissue-friendly material. Of course, we know from literature and from the practice that zirconia is even more tooth-friendly, soft tissue-friendly than lithium disilicate. So this is the 6-month follow-up, and she's cleaning, of course, properly. She's using floss. She's using dental brushes, which I love a lot. And no intraoral rinsing. In this case, it is not necessary. Look at the beautiful soft tissue integration. 4-year follow-up with this specific case. We have no chipping because lithium disilicate is a pretty solid material. We'll talk about chipping and the lamination issues at the end of the presentation and the advantages that zirconia could provide and are in favor of zirconia compared to lithium disilicate. So optimal integration, 4-year follow-up, nice soft tissue. We didn't have any recessions in this area. Careful preparation, careful using of the, during the cementation, we used the retraction cords. Look at the beautiful soft tissue that you can achieve. And now we are at 8 years. She is living abroad. I hope she is soon back and we can add some more pictures of this case, but she calls every 6 months and we have a very stable situation. So in this specific case, we restore aesthetics in a minimal invasive, fast and very predictable way. We published this case in Greece in 2016 and also in Germany in 2016. And it's a case where a careful and meticulous planning and nice execution can provide good long-term results, which are also predictable. So I have some interesting more cases that I would like to share with you. Now, what is more difficult to bring as a beautiful result when we deal with 2 centrals? Even higher level of complexity is one single central that is involved, like in this case, young patient who also had an accident, basketball accident, I think, or ski accident, I'm not sure, in the past. And he waited and waited until at some time point he decided to get married, so he decided to have better pictures for the wedding. So this is the baseline. Okay, we're dealing with the upper right central incisor who has had endo composites, and you see there is also some surface scratches, or surface is also not nice. So in this case, we have to deal with definitely with color, with form, and with surface and surface texture. Sorry. This is, and in this case, of course, our dental technician has to be involved. So the patient is referred to the dental technician, and he is responsible for the lip dynamics, for the color. It's not a case that we discuss over the phone. It's not a case that we define the color. This is a procedure that will be done by our dental technician. This is the delivery day where we do adhesive luting of this Emax veneer, and these are the 6-year follow-up pictures, which are which are very promising, essentially, because again we have a very nice and stable soft tissue architecture, nice color, and the tooth is very, very stable. This is a small video of George. This is his smile. Apologize, everything is in Greek now, so if you can speak some Greek, you will understand. Otherwise, you can tell by the expression, his eyes, he is relaxed. A challenging case. Now, this is Antonis, a young patient, having a bike accident, ugly baseline. Several teeth are involved, mainly the upper jaw, also in the lower jaw, but our focus is on the upper jaw, the tooth fragments. This was a very massive accident that he was involved into, and it's again a quite ugly baseline because essentially we need to redefine all the aesthetic parameters. So in this case, of course, we will use veneers, we will use the 360 crowns or full crowns. You know, it depends on the severity of the fractures that its specific tooth is displaying. Okay, mock-up as a standard procedure because it's necessary to define the aesthetic parameters that are essential for our patient, prep, and final delivery. And this is the 2-year follow-up picture. And this is the way that, of course, with aesthetic dentistry, with adhesive dentistry, with meticulous planning and careful execution, we can get ideal long-term results. Another case I would like to share with you in a fast pace. So each one of these cases, there are more than 700 pictures, but I don't want to kill you with too many details. I want to give you the idea of before, after, and some long-term results in order to figure out how predictable this technique is. So this is a young patient, young female patient. She was not involved in an accident, but there were some composite fillings in the past. A few teeth were replaced by bridges in the posterior segments, maybe some minor discolorations. So on the left side, excuse me, on the left side, it's the initial situation. On the right side, this is a mock-up. And nowadays, you know, mock-ups we can do also more digitally. So we send some pictures to the lab, they design everything digitally, and then we transfer it with a silicon key. So there are many ways for communication. Now, in this case, we involved also some soft tissue alterations in the right side, upper right side, and then again we did some reducing of the tooth structure through the guides. The technique that was proposed by Dr. Gurel, we do it routinely, and we can really achieve exciting outcomes with veneers in these cases. Young patients, a beautiful smile, and a lot of self-confidence that is reflected by, again, minimal invasive, fast and predictable ways. Now, our last case for today is a good friend. He's a dental technician. This is a case that we have been working with him for a long time. So we started back in 2009 discussing about his principal complaints or major problems. 2011, we came into discussion. He's a dental technician himself, so he knows about the extensive protocols that would be required. And his chief complaint is aesthetic and functional handicap. Okay, so this is the baseline, and we see some deciduous teeth, some teeth that show elongation, also missing teeth. So it is a mixed dentition, which is rather complicated. Okay, in that sense, the radiographic image, we have enough bone in the lower right side. We have also to replace the deciduous upper canines. So some implants have to be placed initially, and then later on we go into the full anatomic diagnostic wax up for the upper and the lower jaw, which also needs to do some modifications in the vertical dimension of occlusion. So for sure, we need to go to some open bite measurements. Okay, so this is now a baseline, and the anatomic wax up with corrections in the vertical dimension step by step. Standard protocol, we need to go and every time do these steps. We're not allowed to skip steps. This is the way you should go in simple cases, but also in extensive cases. So our clinical baseline is this. We have healthy periodontium. We've placed already some implants, and we split the treatment in the posterior segment, and to another time point, the latter point, we do the anterior segment. Now, clinical steps, initially prep and depression of the posterior segments, minimal prep in the posterior areas, and these are the CAD/CAM Zirconia posterior monolithic restorations, implant supported or tooth supported. This is all Zirconia. These are Zirconia crowns and inlays, because we wanted to test also in his case how Zirconia is going to perform over time. So 6-7 year follow-up of this type of restoration is a nice baseline. Finalized posteriors with Zirconia. This again, posteriors are all monolithic, and these are the part of the posterior segments, implant and tooth supported, made of monolithic Zirconia, and then adhesively luted on the tooth surfaces. So adhesive luting, there are many protocols about luting Zirconia to natural teeth, and there are some misconceptions. I have another presentation of 1 hour, 1 hour and a half on step-by-step luting of Zirconia, and we have an expertise of over 20 years with Zirconia bonded bridges for the anterior area. So there is some interesting evidence on how to properly and predictably lute Zirconia to natural teeth, to enamel, basically. Okay, so we have now the corrected video, and the posterior segments are completed, and then we continue with the anterior segments. Initially, we go with a direct shell fabrication, again with a durable composite, and we occasionally can send the patient home by wearing these direct shell composites, or we can use it only for a trying period for a few days or a few hours. It depends. It basically is a very good reference for our final prep, but also to evaluate properly the dimension of the final material thickness that we are going to apply. In this case, we can achieve pleasing aesthetics in the upper jaw, which is more crucial in his case. So again, teeth prep, standard protocol. We use the prep technique through the shells, and we reduce as little as possible and as much as necessary. So essentially, we need to reduce rather little amounts of enamel and dentin, because we deliberately somehow overextended the dimension of the ceramics, though our idea was to prep as little as possible. And these are the following pictures of the marginal finish line polishing, final impressions after finalizing the prep, and master cast for dental technicians to work with a veneer. Now, veneer fabrication, again, this was lithium disilicate, a core and lithium disilicate layering. We can go also in a monolithic lithium disilicate pressing, but the decision from the lab part was to use a core and do a layering on top. And of course, this technique provides an amazing aesthetic outcome. So this is the aesthetic outcome after cementation. And he's very, very pleased, and we are very pleased as well. You see, the teeth are not A1 or bleach. We refrain from this paradox of providing two white teeth. I'm not in favor of the very white ones. I like the natural look much more. And he's an older person, so he's very comfortable with the natural shade that we chose. Look at the careful done surface texture that was provided, but also the soft tissue adaptation to this material when it is carefully done. He's very happy. So our patients are really extremely yeah, he's only smiling, you know, he's only smiling. He said it's been so many years that I wish to have this beautiful outcome. But then, you know, we fight about soccer, and about he's a different team than mine, so we have to have also this clinch. Okay, 1 year follow-up, beautiful outcome. Here's, of course, he's wearing a night splint because he's a massive bruxer, and to occasionally have fractures of the posterior teeth. We had also in the past fractures of the posterior teeth that had to be replaced. So in a bruxer, a night guide is always a very nice idea, and it's necessary. So this is the 1 year follow-up. Please check the soft tissue configuration around our lithium disilicate preps. This is the 3 year follow-up. We didn't have any incidents, didn't have any chipping or delamination or debonding. And this is the 6 year follow-up a few years ago. And now we are into the 8 year follow-up due to COVID. He was not able to come to our office, but soon we are going to have pictures of the 8 year follow-up, uneventful situation in his mouth. And please have a look at also the posterior segments. No debonding on zirconia, on this tabletops on zirconia, which is very convincing. I'm very convinced of this tabletop treatment modality. So conclusions in this case: high strength ceramic restorations can simplify treatment outcomes and can make treatment outcomes a lot more predictable. Now, a few words about the porcelain laminate veneers and its engineering. So porcelain laminate veneers are indicated as a conservative treatment modality for anterior teeth restoration in order to enhance aesthetics, function, form, surface texture. What we can achieve with porcelain laminate veneers is excellent aesthetics and minimal tooth reduction. So we're very well within the concept of minimally invasive dentistry. Nowadays, maximal preservation of tooth structure is pertinent. So it's essential that we don't remove more tooth structure that is absolutely necessary. On the other hand, so at one hand, we don't want to reduce to the structure. We want to save as much to the structure as possible. And on the contrary, we need adequate space for the restorative material to possess proper thickness for optical properties and strength. So its material thickness must be guaranteed. In order to be able to follow both principles, we do an extensive pre-treatment analysis. We do the mock-ups. We prep through the guides in order to reduce as little to structure as possible, but provide our dental technician with appropriate material thickness. Because if we save at material thickness, then we potentially jeopardize the final outcome. Now, ceramic materials in general offer high optical properties as a result of a glossy matrix contact in their composition. And this is an effect that we don't have with zirconia, because zirconia does not have the glassy matrix. 15-year clinical performance, these publications, deal with 15-year clinical performance of feldspathic veneer fractures, and they these authors found out that fractures represent 67% of the total failures of such restorations, which is considered the main drawback. So porcelain laminate veneers that are made, out of feldspathic veneer can potentially break. Now, how about zirconia? Or why is zirconia introduced into the porcelain laminate veneer technology? Zirconia-based ceramics, for example, Yttria tetragonal zirconia polycrystal, have been successfully introduced into the daily dental practice to fabricate fixed partial dentures, because we have been utilizing zirconia-based first, second, third generation zirconia for fixed partial dentures, together with CAD/CAM, which is essential for the manufacturing process of zirconia, because they provide excellent biological, mechanical, and physical properties. So zirconia is an ideal material that presents excellent biology, mechanical, and physical properties. So it is a very valuable material to use it for contemporary restorative approaches. So why not also applying it for veneers? Many endeavors have undergone many changes in zirconia composition. So zirconia is a material that is evolving. And the newer editions of zirconia offer increased optical properties without significantly affecting mechanical properties, thereby expanding clinical indications. Okay, so we get materials that are stronger, that are stiffer, and have as good as an optical property as lithium disilicate or ceramics of this category. Consequently, high translucent zirconia has been introduced in an attempt to enhance aesthetic outcomes and overcome the problems that we discussed before, like chipping, like fractures, like delamination over the zirconia substructure. Now, I would like to cite this publication because I was reading a lot about publications that were comparing the performance of zirconia versus lithium disilicate. This is a group from US, I believe. And their conclusion is that zirconia veneers were the least likely to fracture, but the most likely to completely debond. On the contrary, feldspathic porcelain veneers exhibited the opposite characteristics. So feldspathic porcelain veneers used to fracture, but not debond, whereas zirconia used to rather debond and fracture. What does this conclusion actually include? What is the message? The message is that zirconia is an extremely hard material that we can use predictably without having the fear that it will eventually fracture. It will rather debond. And then when we can improve the bonding capabilities of zirconia, and there are many studies on that, then we are dealing with a probably superior material than feldspathic or lithium disilicate. Now, our favorite material that we're working with at the moment is a new product from Aidite, which is Veneers, which is a composition that is designed for laminate veneer restorations. What are the advantages of this specific composition? Well, it has some specific strength and translucency characteristics. So it provides a high strength, like up to 600 megapascal, which is actually a lot compared to other ceramic materials, providing the same optical properties. And on the right side, you see the strength and translucency that are provided by Veneers. So we get additional strength and still get a good amount of translucency that is necessary for aesthetic applications. Plus, during the CAD/CAM procedure, we can get to very, very precise and predictable outcomes. So we have in our hands a material that is stronger and as translucent as comparable clinical materials that are available. There are some clinical cases in the pipeline that I would like to introduce to you soon. We are now in the phase of evaluating and working on some interesting cases. I hope I will be able to present before summer or after summer, because I would like to also highlight on the luting protocols that we are using, and also have some at least like 3, 4, 5 months follow-up for these cases. But I'm very excited because I think that working CAD/CAM, working digitally, and working with high-strength zirconia material can provide very beneficial outcomes for us and for our patients. In that sense, I would like to thank you from beautiful Thessaloniki, my hometown in the northern part of Greece. Today it's a sunny day. We had a lot of snow a lot of cold over the last few weeks, but and you see still my voice is suffering a little. I would like to have you all in Thessaloniki someday. Please email me if you have any additional questions. I hope you had a positive impact of these cases that I would like to share with you. My main scope and my idea was to share with you our enthusiasm about aesthetic dentistry, following the principles of aesthetic dentistry, providing proper protocols, work with excellent materials, and you are going to have a very predictable outcomes. I would like to thank Lei for her continued support. They are doing a great job in China. I have been a few times in China. It's a charming country, lovely people. I wish I could be there more often, but at the moment the borders there is a lot of quarantine there, I think over 1 month. So I hope someday again we will connect. Hope to see you soon in a webinar or live, and I would like to have your questions, and I hope you are happy with this level of presentation. Thank you for your kind attendance. Thank you for being with me. Thank you so much.
Thank you, Kleo. Thank you. Thank you.
Lovely. Bye-bye.
Bye-bye.
See you soon.
See you
Ciao.
soon. Bye.
Thank you.
Thank you so much, Kleo. Thank you.
Yeah, of course. Keep in touch. Bye.
Keep in touch. Thank you so much. Thank you.